I'm John Strum, and this is RealTalk MS. It's May 7th, and we have a lot to talk about. This week, we're wrapping up our coverage of the Aging and MS workshop hosted by the International Advisory Committee on Clinical Trials in Multiple Sclerosis just a couple of weeks ago in Philadelphia. If you happen to miss last week's episode, I'll recommend that you listen to that episode of Real Talk MS, episode number 348, before you listen to this episode. And you'll find a link to episode 348 in today's show notes. With fully half of the MS population over the age of 55, it's imperative that researchers, clinicians, and people living with MS expand our understanding of all the many and varied issues associated with aging with MS. As we age, our bodies undergo biological changes. Our immune system changes with age. Our brains change with age. Our cognitive abilities change with age, as do our physical abilities. These changes impact everyone. But these biological processes may impact people living with MS differently, and MS may impact these biological processes differently. This workshop brought together about 100 experts to explore how all of these changes can affect MS care. And speaking of MS care, a presentation by Dr. Sarah Morrow and Dr. Yinan Zhang focused on a survey of neurologists, rehabilitation specialists, and others involved in MS care. The survey was distributed under the auspices of the Consortium of MS Centers, and Drs. Morrow and Zhang were on hand to share what they learned. I had an opportunity to talk with them about those survey results. I'm talking with Dr. Sarah Morrow and Dr. Yinan Zhang. Dr. Morrow is a professor of neurology and the director of the Multiple Sclerosis Program at the University of Calgary. And Dr. Zhang is an assistant professor of neurology at The Ohio State University. And I'm talking to them both because yesterday at this conference, they presented a very interesting survey that, I'll let them explain it. Actually, it was something that they did with the Consortium of MS Centers. And Dr. Morrow, would you like to explain a little bit about what your survey was about?
Absolutely. So we, as the CMSC, our mandate is to provide guidelines or better care for people living with MS from a multidisciplinary approach. So we are always looking for ways that we can try to help our members improve the care in their MS clinics or those who are working in individual practices. So Dr. Zhang actually approached us to state that he thought that aging in MS was an underrepresented topic in the area of CMSC guidelines. And that's what kicked this off, is that Dr. Zhang thought, is there something we can do to provide guidance to our colleagues who may not have the same experience in aging with MS? And how can we create a document that might be able to help them on a day-to-day basis?
Yeah, absolutely. So, about a year ago when I reached out to the CMSC, the topic on aging and MS is a very hot topic, and we don't really have any guidelines to manage our older adults in the clinic who not only have MS but are also experiencing age-related issues. We kind of along with the CMSC, we identified a panel of experts, and together we developed a survey that we implemented at the 2023 CMSC annual meeting, as well as surveyed the membership through email to kind of gauge what are the healthcare perspectives on needs in the management of older adults with MS.
What did you learn in your survey?
So when we devised the survey, we looked at parts such as, are patients with MS who are getting older, are they being referred to the appropriate specialists? Are there barriers to their care? Are there issues that are commonly identified by providers and patients? And, altogether, we're just trying to see how much of a comprehensive geriatric assessment is being implemented by neurologists and how closely they are working with multidisciplinary specialists and their primary care providers.
We also wanted to ask what they felt was missing, both in terms of being able to provide the appropriate care, so both in terms of what evidence is there, as well as what guidance is there, also what resources they do or do not have that they feel would be useful for an aging MS population.
So tell me, what were some of the issues that rose to the top of the list?
Yeah, so, unsurprisingly, physical and cognitive function are big issues that are identified by providers as those that are facing older adults with MS. But other issues like the appropriateness of discontinuing disease-modifying therapies or being able to tease out age versus MS-related changes in the MS patients, these are all very commonly cited issues of concern.
And these are things I even hear anecdotally from neurologists who are treating older patients with MS. They'll say, gee, if somebody is walking a little slower today, is that their MS causing them to walk a little slower? Or is it simply because they're aging?
And I think we all have that confusion. I think patients come to us and say, I'm not sure what this is. Is this normal for my age? My friend down the street can't walk as far as that because of our age together. Am I the same as her, or is this due to my MS or something else? And I think that's one of the main issues we wanted to also address, is how to tease out those changes that are MS related versus those that are due to other comorbidities. Meaning, is it something that we should be addressing, that their MS is progressing and we should try to change their disease-modifying therapy or address certain symptoms? Or should we be involving perhaps a generalist or their family doctor to be treating perhaps their arthritis or their diabetes or something else that might also improve their quality of life?
So I'm glad you brought up comorbidities. As anyone ages, it's more likely that they will develop different health conditions, and that's probably equally true for someone living with multiple sclerosis. They're going to develop these other comorbidities, these other health issues that also need treatment, but also make the whole diagnostic process a little trickier, doesn't it?
Mm-hmm. I think sometimes we have to remember that our patients don't just have MS, they could have other things. And there's good evidence that's been published, and we're going to be including it in our consensus statement, that people with MS are less likely to be diagnosed or diagnosed in a timely manner with these comorbidities, which means we're missing the opportunity to treat them appropriately. And sometimes these comorbidities are not just additive, meaning having MS plus those other comorbidities isn't just 2 + 2 = 4, but it could be 2 + 2 = 6 or 8 and have a bigger impact on people with people living with MS. And on top of that, we may not be appropriately screening them for these other comorbidities, because it's easy to say this problem is from your MS, your walking problem is from your MS, or this problem is from your MS, and we're missing the opportunity to see what else might be treatable in their overall care.
I wonder if this even bleeds into a bit of a resource issue. That neurologist in the examining room, when we're talking about things like comorbidities, being able to tease out age-related versus MS-related issues, that means that exam is going to take longer.
Absolutely. So, in our survey and at the end of our meetings with the expert discussants, we identified 5 areas which were key to address in older adults with MS, which we will focus on in our consensus statement. And first one is the use of disease-modifying therapies in older adults. Number 2 is the integration of multidisciplinary specialists in the care of older adults with MS. Number 3 is comorbidities and polypharmacy in people with MS. And then number 4 is age versus MS-related changes, and number 5 is access to care. So, across these themes, like you mentioned, there's certainly an issue of potential resource in access to care, such as patients having the transportation, the financial means to be able to afford or participate in their care regimen, and also whether centers, whether it's a general neurology clinic or an MS center, do they have the presence of specialists like physical therapy, urology, MS pharmacists, even dietitian and neuropsychology and so forth. So these are all issues that relate to the utilization of resources.
I think we often talk on this podcast about the benefits of comprehensive care, of having a team approach to treating MS. It sounds like as people age, that team may change, may grow, may have new members based on new needs.
Absolutely, yeah. So one of the examples is at Ohio State, I helped develop an Aging with MS clinic. This is a multidisciplinary clinic designed for older adults with MS, say over the age of 60, but we don't have a strict age cutoff. So when patients come into this clinic, it's a referral for a 4-hour-long visit during which the patients are seen by a variety of specialists that includes our physical therapist, our nurse practitioner in MS, our social worker, and MS pharmacist, a dietitian, and neuropsychologist. And they not only address the MS-related issues, but also the aging-related issues, and they perform a comprehensive geriatric assessment looking at medication interactions and so forth. And we can altogether provide a lot of helpful advice and management options.
I remember hearing in your presentation yesterday that there was an overwhelming majority of your survey respondents who indicated there was a real need for best practice guidelines about treating people as they age with MS. So what's your next step?
So we have, based on the survey, and as Dr. Zhang indicated, we've come up with the 5 topics we're hoping to cover. We'd originally hoped that we'd be able to provide comprehensive best practice guidelines, but what we realized during our survey, and I think is coming out through today's meeting, is that there's still a lot we don't know. So we kind of framed it as what we know now and what is the best evidence for what we have now, but also what is unknown. It was something that we may use to grow in the future, where we should look for future resources as well as look for future research to say how can we provide the best care for these aging MS patients. So it will still be best practice guidelines, but it's going to be framed in a call to action where we're hoping that we can build on what we already have and create more evidence for better care in the future.
So I know we're roughly a month away from the next CMSC annual meeting. This project got its start at the last one last year. We'll be at that meeting. Are we going to hear about this project?
Not quite yet. Our consensus meeting is actually taking place at the same time as the meeting, where we are hoping to finalize the document. But we do hope to present our results both through some online activities as well as the next CMSC meeting in 1 year.
And of course, you'll be willing to share that with our podcast listeners.
Of course.
We'll look forward to it.
Thanks so much, Dr. Morrow, Dr. Zhang. I appreciate all you do to make life better for everyone living with MS and how you're focused some of your efforts on making life better for people as they age with MS. Thanks again for talking with me today.
Thanks for having us.
Thanks.
Advances in technology are paving the way to more discoveries in science, health, and medicine than we've ever experienced as a civilization. And those include discoveries about how the brain changes as people with MS continue to age. I spoke with Dr. Giuseppe Portillo about the role that artificial intelligence can play in analyzing brain imaging and predicting future MS progression as an individual ages. I'm talking with Dr. Giuseppe Portillo, who literally just came off the stage after giving a presentation on the brain age gap, and we are going to talk about that. A couple of foundational questions to help my listeners. Can you briefly tell us what machine learning is?
Yes, so to put it simple, machine learning is a branch of artificial intelligence when you can use models to understand patterns from data with the objective of maximizing the prediction on new data. So it's basically, in classical statistics, you have to set up a model to tell the model what you want to see. With machine learning models, you don't have to do that. The model is able to understand the patterns by itself from the data. And the objective there is to maximize the prediction on new data that hasn't been seen by the model during the training phase.
So if I can tell a brief story to help illustrate this, actually there was an engineer at NASA who was very interested in machine learning on his own. He taught a computer how to look at outer space by having it process tens of thousands of photographs from satellites. Based on that information, the computer observed that there were two planets, far distant planets in outer space that NASA didn't know about, but the AI was able to locate. So in our case, we're not talking about outer space, but inner space, specifically the brain. I hope you'll explain what brain age means.
Yeah, I'll try to put this simple. Basically, the brain changes with age, and this is reasonably consistent across subjects. This means that if we use a machine learning model, we can input neuroimaging data like brain MRI scans and try to predict chronological age. Once we do this in a very large cohort of healthy subjects, we obtain a model of healthy brain aging, and we can use this model to predict age on new subjects. So from the model, we will have a predicted age, and of course we know the chronological age of the subject. And so we can say the brain of this subject looks 10 years older than expected, 10 years younger than expected, looks like exactly his chronological age. We can have a measure of what his age should be based on the appearance of his brain.
And as we've heard a few times during this conference already, that the brain age of someone living with MS usually appears older than their chronological age. Is that correct?
It is correct indeed. Of course, the magnitude of this effect depends a lot on the disease phase. In very initial phases, you can have brain age gaps that are very close to zero, like healthy controls. But then when you go into progressive phases, this number tends to increase. And so you can have brains that on average look 10 years older than the healthy people.
So now that we understand brain age and chronological age and how they correlate, what is brain gap?
All right, that's what I was saying. It's basically the difference between the biological age of your brain predicted based on some neuroimaging data and your actual chronological age. So it can be positive, negative, or it can be zero, meaning that your biological brain age and your chronological age align perfectly.
So among people who are living with MS, does the brain age gap, the difference, correlate to MS symptoms?
It does indeed. And also it's very promising in how it does that. But actually we need more and more head-to-head comparison with more established biomarkers. Because as a biomarker it is very promising. It explains symptoms, it explains progression over time, it explains many clinically relevant features of MS. But we need some more technical validation. We need also some head-to-head comparison with the already established biomarker to see if this is really adding something to what we already use in MS.
We know that MS tends to progress over time. Does that brain age gap increase over time?
Absolutely. And you have to think that by definition, in healthy subjects, the brain age gap on average tends to remain constant over time and tends to average zero because the chronological age on average aligns with the biological age. In MS patients, this does not happen because the brain age gap tends to significantly increase over time. And this means that this measure is being sensitive to damage progression in the brain that is related to the presence of MS. So it's also a measure that is sensitive to disease progression over time.
I think I heard you say this a minute ago, but I think it's worth circling back to again. Is the brain age gap predictive of future disability worsening?
Yeah, it is, at least based on at least a couple of studies. People who at time zero have a higher brain age gap are also the ones that are at a higher risk of developing confirmed disability progression over time. So it could be used also as a prognostic biomarker.
Well, that's really promising news because certainly we don't see enough prognostic biomarkers at all yet. And that would make a huge difference from the patient perspective. Certainly giving someone an opportunity to understand what their disease course is likely to be, and also from the clinician's point of view, how aggressively we want to treat that patient.
Absolutely. We want to have early biomarkers that can say, oh, right, this patient is going to progress in this way, so we have to be more aggressive, or this other patient is going to progress more slowly, so we can be less aggressive. We want to be able to tune our decision making based on objective biomarker, and the brain age gap is a very promising candidate for that.
And so this kind of technology-driven tool really is going to help us get to that point of personalized precision medicine.
Absolutely. That's the whole point behind this. We want to have a biomarker that is useful at the single subject level, that can really orient clinical decisions at the single subject level.
Well, thank you for giving us a peek into the near future, we hope.
Thank you so much for having me.
And Dr. Giuseppe Portillo, I want to thank you for all the work you do to improve the lives of people who are living with MS. Thanks again for talking with me.
Thank you so much for having me. It was really a pleasure.
As people living with stable MS age, it's not unusual for them to consider discontinuing their disease-modifying therapy. Dr. John Corboy is a professor of neurology at the University of Colorado School of Medicine and the director of the Rocky Mountain Multiple Sclerosis Center at the University of Colorado. Dr. Corboy is also the principal investigator in the DISCO MS clinical trial, the largest clinical trial to focus on whether it makes sense for someone over the age of 55 or 60 to discontinue their DMT. At the workshop, Dr. Corboy presented updated findings from a follow-on study to DISCO MS, and after his presentation, Dr. Corboy and I discussed his research. While our entire meeting is dedicated to understanding, or I should say better understanding, aging and MS and determining what questions still need answers and what answers might already be available, I have to say that I don't think that there was a single topic that generated quite as much engagement as the one about discontinuing disease-modifying therapies. And I think, interestingly enough, if you had a room full of people living with MS, that would also be their top priority in finding more information about. And we're very fortunate today to be joined by Dr. John Corboy, who was principal investigator for the DISCO MS study, and since then has some new information he's going to be sharing with us. But first, welcome back to the podcast, Dr. Corboy.
Thanks for asking me back, John. I really appreciate it.
You bet. And I think before we get to some of this new information that you shared at today's meeting, can you just refresh some of our listeners on what DISCO MS was all about and what the outcome of that study was?
Sure. The background with DISCO MS is that, of course, people might use these medications for years, and the question is whether or not they are effective as people age, and whether or not the risk may also increase with using them. And so the question arises as to whether or not potentially either slowing down and de-escalating therapy or ultimately discontinuing therapy makes sense. So there are a number of observational studies that have suggested this is reasonable, but at the same time, we would like to do randomized control trials, and that's what we did with DISCO MS. And it was in people 55 and older who had not been having a relapse for at least 5 years, no scan change, MRI scan change for at least 3 years, and then but had been on therapy that whole time. And we're asked a simple question: if you go off, are you having an inferior outcome? Do you do worse than people who stay on medications? And we judged as the primary outcome measure whether or not they would have an acute relapse of their MS symptoms or if they had any new brain MRI scan lesion. And what we found was that we could not prove that it was non-inferior. I know that's a lot of double negatives, but we couldn't prove it was non-inferior. But what we really showed was that there was a small increased risk probably of having 1 or 2 new lesions on your brain MRI scan, but all the clinical measures really didn't show much in the way of any differences between people who stayed on medication and those who went off. So while that could be important, we didn't find that there was a relationship between 1 or 2 new lesions on your brain scan, which were very few and far between, but which were different between the groups, and any other measures of clinical problems, such as having a change in your examination with worsened disability or any relationship to patient-reported outcomes or other things like that.
I think for some people living with MS, they could readily provide the answer to this question, but I'd like to hear your answer. What are the benefits of discontinuing disease-modifying therapy for someone over the age of 55, 60?
Sure, and it might be different for different people, but there's a broad array of things that might be beneficial. Number one, it may be cheaper for you. You don't have to pay copays and deductibles. Two, you might have side effects every time you take that drug. Three, for many of our better drugs, which might have a long-term risk of perhaps infection or even malignancies, you can reduce that risk substantially. And another one that's not really thought about much, which our patients mention in a lot of different studies with surveys and things, patients don't like being reminded that they have MS, and especially every time they have to take a medicine, especially a medicine maybe once or twice a day, they are reminded that they have MS. And so the freedom from having to sort of think about that and having to take a medication on a regular basis is freeing for a lot of people.
Makes sense. So since the outcome from DISCO MS was reported, talked about, in fact, if our listeners want to learn more about it, they can listen to our initial conversation about it in episode 255 of Real Talk MS. But since then, there's been an extension study.
There has been an extension study. It's not yet published, but we reported it at meetings, and it's going to be hopefully published very shortly. And in the extension trial, we had a limited amount of money, so we could only look at a few of the centers, 9 of the 20 original centers, and we only wanted to look at people who had stayed on their original assignment, either on drug or off drug, and who had already not achieved the initial outcome measure of either a new relapse or a new scan change. That is, we didn't want to count them a second time. So when we did the one-time visit for the extension, as opposed to 2 years in the original study, we were now out to about 40 months, so not quite 3.5 years of follow-up. But it was a restricted population. Now it was only about a quarter of the original population. 30 individuals who stayed on drug, 44 individuals who went off of drug. And what we showed with this one-time visit now, a year and a half later essentially, was that there were no relapses in that group, in either group. And in addition, there were only 3 people, 1 of the continuers and 2 of the discontinuers, who had any new activity on their MRI scan. So similar to the first part of the study, very, very few relapses, in this case none, and also very little new disease activity on a scan. And so what this really told us was that there was no delayed effect. There was nothing that occurred at least out to 2.5 to 3.5 years now. And that was reassuring, because that was the number one thing that patients were concerned about with the DISCO study. It just simply wasn't long enough.
That's interesting that in the extension study, you talked to people who had basically stayed on the plan they were on during the DISCO study. Were they given any instruction at the end of the study? For instance, now that your participation has been completed, go back to your disease-modifying therapy, or don't go back to your disease-modifying therapy? Was there guidance there, or was it left up to them, or how did that work?
So this was at 20 different centers, so it was really left up to all the different practitioners and the patients at the different centers. And so it did create a little bit of a bias in the sample, if you will, because some people, when they heard the original results of DISCO, if they're in the continue group, they discontinued, and they were no longer eligible for the extension. There was only 1 or maybe 2 people that went in the other direction who had been randomized to go off drug and then went back on. And that's why we had a little bit of a mismatch in the groups, only 30 continuers and 44 discontinuers in the actual extension study. So it's important to remember, it's no longer a randomized trial when you go into the extension. Now people have sort of chosen which side they want to be on, and that's in fact a limitation of the study.
Well, as people in the study chose which side they wanted to be on, I know a lot of people who would qualify based on age and based on their current health status with their MS. They're also choosing sides. Where do we go from here in trying to determine best practice when it comes to discontinuation of a disease-modifying therapy?
I think the way we go is somewhat what the extension study suggested, which is to do longer studies, better studies, and really try and hone in on, is there an algorithm? Can we say a certain age with a certain disease duration, with a certain amount of time since you last had a relapse? What are those factors, when you take them all together, can you come up with an algorithm, a scoring system that would allow us to say, this will put you in this level of risk, and something else would put you in a different level of risk. But on the flip side, I think we also need to remember that we're always judging the potential benefit of these medications against just no benefit from being off the drug. We also have to remember the potential risk of staying on the drug. So I think we need to do a lot better job in our older patients of understanding their risks of staying on the drugs. And also the third thing we need to do is we need to really understand what the patient's view is. You alluded to the fact that patients are choosing sides. When we did a study outside of disco, but related to it, and asked people, would you be willing to consider a trial off medication? These are people who are on medications they have chosen already to stay on. When we asked them that question, and they were a similar age and everything to the disco population, 66% said they would not be willing to consider a discontinuation trial. This was, again, before we had the data, though. And so now part of our job is to educate people as to what the benefits or perhaps lack of benefits might be with continuing drug, but also better understand the risk of staying on the drug, and then help them make a decision so we have the shared decision-making going forward. That's the key.
Well, Dr. John Corboy, I want to thank you for really exploring a question that everybody is anxious and interested in its outcome, and wish you best of luck in your continued exploration of that question. And thanks so much for talking with me today.
Thank you, John. I appreciate the offer.
One thing that the workshop attendees were in clear agreement about is that the work toward advancing our understanding of aging with MS had to include the voice of people affected by MS. My friend Kathy Smith is a scientist, now retired, who was diagnosed with MS in 2004. Kathy shared her perspective as someone who's living with MS during a panel discussion on clinical research and older patients. Afterward, I spoke with Kathy. I'm talking with Kathy Smith, who is someone living with MS. Full disclosure, Kathy and I are old friends from our days on the International Progressive MS Alliance Scientific Steering Committee. And Kathy has been attending this entire 3-day meeting. Yesterday, Kathy, you participated in a panel discussion about clinical research and older people who are living with MS. Today, people over the age of 55 are routinely excluded from clinical trials. So I guess if I asked you, should people over the age of 55 be included, it would be a very short answer, and I think I know what your answer would be. Let me phrase a question this way. Why is it important that people over the age of 55 be included in clinical research?
Well, John, thank you for inviting me to be here with you today. And yes, it's great to catch up both on mic and off mic. But it's a great question. I think that the main reason why people over the age of 55 should be included in clinical trials is because so we heard that 50% of people living with MS are over the age of 55. And therefore, if you want to have a clinical trial that represents the MS population, you need to include that half of the entire community that are over 55.
So if you'll allow me to play devil's advocate for a moment.
Okay.
As I've already mentioned, as people age, and this includes people with or without MS, they're likely to develop other health conditions. Their EDSS score often changes because their mobility changes. They often demonstrate less physical or cognitive reserve, and typically they are experiencing fewer MS relapses as they age.
Yeah.
So given all of these prevailing conditions, wouldn't their presence in a clinical trial sort of bias the results?
Mm-hmm. The short answer is I don't think so. I think that what we know is that most, or if not all, the therapies that we currently use in MS are very good against the inflammation that occurs in MS, but but that's what's happening in mostly the younger population. And so, and I think that now, the community and companies are thinking about how do we really tackle progressive MS. And so I feel there's a huge intersection between progression or progressive MS and aging, and that we're not introducing bias, but rather actually studying the population that's most important, who are progressing as they're getting older. When I think about bias, maybe somebody's talked about randomized controlled trials. And so if you were to set up a trial studying, 2 different treatments or a treatment and a placebo, you have to have a group that is matched in both arms of your study, and therefore you would hope, well, you're not hoping, but you're imagining that in each group you have the same amount of comorbidities, you have the same amount of normal EDSS progression, and that those with on either side will balance each other out.
So as long as we make sure that both in that healthy control group and the group of trial participants who actually have MS, if we are matching them age-wise, they'll bring similar conditions, and that sort of, as he points out, balances things out.
Yeah, and age and maybe other characteristics. So, you might choose some other characteristics or comorbidities that are allowed or not allowed in both, but equally not allowed in both.
You make a very good point when you talk about the intersection between progressive MS and aging with MS. And as 2 alumni of the Progressive MS Alliance, I'm wondering, do you think that the Alliance should be focusing a bit on the concept, the subject of aging with MS, as you point out, it's likely that as people are aging, their MS is progressing, and we have this incredible global effort being made today on progressive MS, and maybe that's an opportunity to really elevate the conversation when it comes to aging with MS. Yeah. What do you think?
So I think yes, and I think no. So I think yes, from the point of view that there are many common features of aging and progression that. So in that respect, I think, yes, there ought to be certainly collaboration and sharing and focus from the Alliance. And I'd like to say no from the perspective of that I'm not sure that, so we spent 3 days talking about aging, and I'm not sure that aging is really what we should be talking about. I think that functionality and disease state may be what we should be talking about more, given that there are people who are 40 who are progressing very rapidly, and they may look exactly like someone who's 60 or 70, or you have someone who's 60 or 70 who looks absolutely normal and isn't progressing. So who fits together with who in the research? Is it the actual chronological age, or is there more about biological age and disease state that we ought to be focusing on?
Fair answer. Well, let me ask you, making the case that we really need to rethink who participates in clinical trials. Who leads the charge in making clinical trials more inclusive of older people who are living with MS? How are we going to get there?
Well, I think that certainly in the United States, the NIH is very much leading the charge. So they've come out with I think they call it across the lifespan policy for inclusion of older people in clinical trials. So I think it starts there, or it has started there. The National Institute for Aging has picked that up in terms of requiring that their grant recipients design their trials to include older people, and they won't get funded if they don't, or they have to have a very good reason not to include older people. And then I think it's the MS community. I think we've heard from the neurologists in the room here that we need to increase older people in trials. I think the debate is more about, well, how do we do that, and do we need to sort of stratify or subgroup people as they go forward? And I think that National MS Society can be a huge driver in getting that done.
Well, Kathy Smith, thank you for lending your voice and speaking on behalf of so many people who may not be in the room, but whose point of view and perspective you clearly represent. And thanks so much for talking with me today.
Thank you, John. Always a pleasure. Thank you.
The final session of the 3-day workshop focused on charting a path forward, and the Scientific Planning Committee identified 4 steps that would follow our 3 days in Philadelphia. It was announced that a paper summarizing the meeting would be written and submitted for publication in one of the scientific journals. A working group or task force would begin working on formalizing some of the issues that rose to the surface during our 3 days of presentations and discussions. The International Advisory Committee on Clinical Trials in MS would engage with regulators at the FDA and EMA around expanding the age criteria for clinical trial participants. There would also be an effort made to engage with Medicare and private insurance companies about defining an evolving treatment strategy for older people living with MS. And finally, the Planning Committee reiterated their commitment toward including the perspective of people living with MS in every step and stage of this work. One day in the foreseeable future, someone's going to say, there was a time when older people with MS couldn't even participate in clinical trials. In that moment, we might also recall that the work, the effort and attention necessary to create positive change for everyone living with MS may have been launched at a 3-day workshop in Philadelphia. That's going to wrap up this episode of RealTalk MS. RealTalk MS is powered by the National MS Society. And you can share this episode of the podcast by letting your friends or family members know that all they have to do is point their web browser at realtalkms.com/349. You'll find that link in today's show notes, so you can easily copy and paste it right into an email or a text. And if you have a minute, I hope you'll visit the Apple App Store or the Google Play Store and download the free RealTalk MS app for your iOS or Android smartphone or tablet. It's the best way for us to stay connected. The app will automatically download the latest episode of RealTalk MS. You'll be able to access any of our past episodes. You'll be able to save your favorite episodes. And it's a great way for me to share bonus content with you. The app is free, so I hope you'll download it today. I'm John Strum. Thanks for listening. Stay safe and make healthy choices.